everybody. I think I know pretty much everybody here, except for a handful of people. I see there's somebody from Catch here. That's cool. You can chime in and correct me on anything that I get wrong here. Nice to have a real expert in the room. But thanks for taking the time to be here, everybody. I'm going to share my screen here. Okie doke. So we're talking about homelessness and healthcare. Most of this talk is going to kind of focus on, or I guess a chunk of it will focus on Idaho specific things and some national trends and whatnot. And then some things that have been going on in Boise more lately. This is the required accreditation and disclosure slide. I haven't read this before, and I'm not going to read it now, but it's there. Goals. From a clinical standpoint, I think the goal for listeners today is really just to kind of get more familiar with homelessness and its impacts on health, both on a national level and on a local level. And then we're going to kind of take some time talking about misconceptions and biases, kind of preconceived ideas about homelessness and folks who are experiencing that, that might interfere with your care of those individuals. And then we'll talk a little bit about ways that you can move some of this in your practice in one way or another. And then just a more kind of specific outline here. We're going to talk first, just go over some kind of recent stats and data from like PIT counts and things like that, just to get a sense of kind of what's happening with homelessness in the country right now and in our region. And then we'll kind of talk more about those misconceptions about this population, impacts on health, and then kind of dive into some local things here. So recent trends, a lot of this data is based on PIT or PIT count data. For those of you that don't know what that is, that's a point in time data that's collected once a year, kind of on one single day, where teams go out and try to just count individuals who are experiencing homelessness, both at shelters and in various unsheltered locations. Lots of limitations with these data sets in terms of like inability to actually physically find everybody, and just missing kind of trends and variations of homelessness throughout the year as those numbers shift throughout the year. But it's kind of the best we have to give us a sense of the scale of this problem. So we're going to go through kind of Idaho's PIT data from 2025 for starters here. Statewide numbers, just under 2,700 folks experiencing homelessness in Idaho. There's kind of a trend over the last few years and a breakdown of sheltered versus unsheltered folks kind of falling in this category. You see numbers are a little bit less than they were last year. Across the state of Idaho, it's about 50-50 on the nose, actually, in terms of sheltered versus unsheltered homelessness, which is kind of a perfect number. And then demographics here for 2025 data, age-wise, you'll see, the majority of folks are adults, kind of young to middle-aged. There's, about a quarter of folks who are above the age of 55, and a good chunk are under the age of 18. And then gender breakdown, majority are male. I was unable to find for just 2025 data in Idaho specifically. Somehow I was not able to find race ethnicity data. So unfortunately that's not available. We'll see that a little bit on a national level and an Ada County level, but for whatever reason, that wasn't included kind of in the resource that I was looking at here. But this just kind of gives you a snapshot of the kind of scale in the state and kind of who these folks are demographically. And then regionally, there's a lot of interesting variations in terms of the degree of homelessness throughout Idaho. And I also just want to call out some really fascinating differences in terms of sheltered versus unsheltered status. You'll see later in the talk that impacts a ton of things in terms of outcomes and health outcomes for individuals who are experiencing homelessness. It's just access to shelter while they're unhoused. And rates of sheltered status just vary dramatically throughout Idaho. And again, keeping in mind, like on average in Idaho, about 50% of folks experiencing homelessness are sheltered, and 50% are unsheltered. But here you can see in kind of region 3, the vast majority of folks are unsheltered. And in region 4, vast majority are sheltered. So lots of differences regionally. I know probably most people on this call are from Southwest Idaho, but it's just important to kind of keep in mind that the landscape just differs really dramatically depending on where you are in the state and where you are in the country. Some Ada County data specifically, this was pulled from I think our Path Homes website had data. Again, on the left, kind of this first chart is just kind of total trends over the last few years for Ada County numbers. So there's 772 in 2025. And again, majority of those folks are sheltered or in transitional housing, and kind of a smaller chunk here are unsheltered. And then age data breakdowns on the HUD website. Again, most of these folks are adults, vast majority white. The next kind of chunk of slides are pulling from national PIT data. And the 2025 data were not available when I was putting these slides together. So this is the 2024 data. But just to compare Idaho to the rest of the country, here in Idaho, we kind of have a moderate or kind of a middle of the pack rate of homelessness here in the state compared to other states, but we do have a higher rate of unsheltered status among this population, and then a higher rate of rise of homelessness in this state. So we can kind of see this graphically. This is just kind of showing rate of homelessness in the state measured as people per 10,000. We're kind of right in the middle of the pack there, 10 to 25. But having a higher rate of rise compared to other states, I counted these this the other day, and I forgot the number, but we're somewhere around like the 10th or so in the country for kind of rate of rise of homelessness. And then back to this kind of sheltered versus unsheltered status. We're also kind of at the bottom of the pack here. We have lots of folks proportionally who are unsheltered. Nationally, the PIT data report, for anybody who's interested in this, is super interesting. It's super, super dense. There's a lot of information. I just kind of, when I was sifting through and looking for kind of recent trends, just pulled out things that I thought were interesting or fascinating to me, and hadn't really made it to me through like typical news channels in terms of trends. So that's kind of what I included here, but by no means is this like a totally comprehensive review of the 2024 PIT data. So if you're interested in learning more, then there's plenty more reading to be done. But a few things that I thought were interesting on a national level was rising rates of suburban and rural homelessness as opposed to urban. I think we often think of these problems as urban problems with locations with really dense populace, but that's no longer this problem is no longer isolated to those areas. And then I have been hearing a lot over the last few years about kind of the aging population of, or how the homeless population is aging in general. And I think that has been true. But recently, and we'll look at this data in just a moment, there's been a pretty big rise of youth homelessness and kind of young family homelessness as well. And then this last point is not a new point. Or not a recent change, but I think something to just continue to call attention to is the fact that people of color are really massively overrepresented in this population. We'll dig into that a little bit more later. But here's just some kind of numbers. Sorry to throw so many numbers at you with this presentation. I'll kind of highlight what I think is interesting here. Kind of just calling attention to the rise of suburban and rural homelessness. Just kind of these left two columns are just pointing out kind of the change in total individuals experiencing homelessness in these kind of different COC categories. So kind of major cities, other urban areas, suburban areas, rural COCs, and suburban and rural kind of have the highest rates of rise overall. And then especially looking at on the far right, kind of the change in unsheltered individuals, the highest area where we see that rising is in suburban and rural areas, primarily because these areas are places that haven't been dealing with a lot of homelessness and likely don't have the same infrastructure that a lot of these urban areas have. so there's not as many resources. And for a lot of us that are either practicing in rural areas or going to rural areas, I think that's a really fascinating thing to keep in mind. Some age data on a national level, again, kind of highlighted in red on the right. Here is just kind of the change that, more recent changes in age categories, and you'll see the under 18 age category is the fastest growing, as opposed to the above 55. It's actually quite a bit lower than that. So I thought that was really fascinating, and kind of again goes opposed to what I have been hearing a lot of in the news about kind of this aging population, which I think is true, but this more recent kind of trend is something different than I was expecting. And then here's just kind of a trend over time of families with children experiencing homelessness. And so you can see over the last few years, kind of that sharp incline. And that's kind of both sheltered and unsheltered. Similar to Idaho and Ada County, on a national level, vast majority of folks experiencing homelessness, or not vast majority, but the majority are male. We're not going to dig into all these numbers here, but they're there if you want to come back and look at those. And then in terms of race, ethnicity, majority, minority status, the people of color, minority groups are just massively overrepresented in this population. So 2024 census data had about 25% of the U.S. population as being people of color, majority, and PIT data from that same year is almost 70%. So it's just a wild disconnect there. Here's kind of all the numbers again that the 2024 PIT data had. If you're interested in coming back and looking at this, again, we're not going to spend too much time going line by line here, but I just wanted to have that in there for anybody who's interested in taking a closer look at that breakdown. Okay, that's kind of just some of the more interesting things that jumped out at me looking at the 2024 data and 2025 data for Idaho. In this next chunk, I kind of want to focus on misconceptions that folks have about homelessness and folks experiencing homelessness, really with a goal of kind of combating the way these misconceptions can impact our interest in this population, our ability to connect with this population, and hopefully kind of address some of the barriers to their care. These are kind of like the 5 things that I think have jumped out at me over the last year or two working with this population that I wanted to focus on with this talk. And this first thing we're going to talk about is just individual versus structural factors that contribute to homelessness. Some of you may have heard of this book. It's called Homelessness is a Housing Problem. It's a really incredible book. It's written by the 2 folks listed up at the top of that picture. It's an analytical book. It's a research project that was published in book form. I think they were from UW. And really their research question for this project was related to national variation in homelessness in different cities, and trying to address the question of why are there such differences in different parts of the countries with regard to kind of frequency or the degree of homelessness in these different cities who otherwise are similar in some ways and different in others. So just kind of pulled out kind of the primary findings for this. And really the takeaways are here. There's lots of individual level vulnerabilities that are correlated with homelessness. There's lots of research data showing that. We see that in some of the data we just went over, looking at things like age, race, ethnicity, gender, poverty status. And all of that said, individual level factors alone really do not explain causal pathways to homelessness. And this book does a really good job showing that from a statistical lens. And they don't explain geographical variance in homelessness. And at the end of the day, that variance is a lot better explained by large picture population shifts and housing elasticity, and the availability of housing and kind of infrastructure. And we'll dive into these points just a little bit one by one. like we were just chatting about, lots of individual level factors that are associated with homelessness. We're not out here doing RCTs to look at who loses their housing and who doesn't. And so we have poor quality data at best and just a lot of kind of snapshot, point in time data. And a lot of the literature on this topic kind of looks at attributes of individuals that are associated with homelessness, things like identities, age, race, gender, sexual orientation. And there's lots of things that are mechanisms that can lead to homelessness from kind of this lens: societal discrimination, structural barriers, exclusion. And then the literature also talks a lot about vulnerabilities, things like poverty, mental illness, substance use, domestic violence, social isolation, some of the kind of next level kind of environmental factors and vulnerabilities. And this area gets a little messy because a lot of these things are bidirectional. There's a lot of studies showing that folks with poverty or substance use might be more likely to become homeless or to lose their housing. But there's a lot of that mechanism also works in the other direction, in the sense that folks who become unhoused are more likely to then start using substances for a variety of reasons, and some of which are functional reasons, to stay awake, etc., on the street, and are then more likely to develop mental illness, more likely to be subject to domestic violence. And so there's a lot of bidirectionality here with a lot of these vulnerabilities, and it makes it hard to really understand causal pathways. But I think at the end of the day, some of the big takeaways that I want you to leave here with is that these individual attributes and vulnerabilities do not cause homelessness, and that's kind of the one of the core takeaways from this really well-written statistical analysis, that they are not the cause of homelessness. They're correlated with it, certainly, but not causing it. And it's important to remember that the majority of people experiencing homelessness don't have these attributes and vulnerabilities, and the majority of people with those vulnerabilities and attributes don't lose their housing. So there's a lot of other factors that go into this, kind of outside in one individual's attributes or vulnerabilities. So that's just important to remember. And then we'll get a little bit into the stats of this book here. But we're not going to talk about all of it. They did a lot of really cool analyses looking at kind of multi-level modeling and looking at kind of geographic or regional factors and correlating those with homelessness to kind of back up this claim. And we're going to walk through just a little bit of that right now. But based on what we know about these correlations and population differences, you might assume at a starting point that cities with higher rates of poverty, for example, or proportionally more people of color might have higher rates of homelessness based on what we see in the PIT data, and that's not true when they look at that on a regional level. And what they actually found is that homelessness rates were higher in cities that are disproportionately white, have higher median incomes, and lower rates of unemployment, less poverty. And we're actually more associated with affluent cities than cities with poverty. So it's kind of opposite of what you would expect. And here's just a couple snapshots of data, kind of looking at homeless rates per 1,000 on the y-axis, and then poverty rates on the x-axis on the left, and then kind of percent identifying as Black or African American on the right. We know this population is higher represented in the homeless community. And neither of these things really correlated at all in the way that you would expect them to, meaning cities with higher poverty rates or higher amounts of non-white individuals were not found to have higher rates of homelessness. And so kind of the takeaway from this is the individual level factors, whether that's attributes or vulnerabilities, might explain who becomes homeless in any given city, but they don't explain regional variations or kind of the true causal pathway of like what's causing homelessness to be higher in one part of the country versus another. And ultimately, the kind of the conclusion they end this book with is that homelessness is driven by really population growth and housing elasticity, the availability of housing, particularly low-income housing and supportive housing. And they kind of have these two things plotted here. And you see kind of this bottom right group of cities just constantly called out in the media as having very significant housing issues and high rates of homelessness. And this tracks well with this kind of theory that they present in this book in terms of there's lots of population growth in these cities, and there's not a lot of housing elasticity. There's nowhere for new people to go when they come in, and so the housing markets change, prices go up, and folks who are then more susceptible to homelessness based on other characteristics are unfortunately the ones that are pushed out of their housing. Okay, so that's all we're going to talk about from that book. I would recommend reading that if you have any interest in this topic. It's a good read. These kind of next four misconceptions and topics we're going to kind of go through drawing on this data set, which is a super, super cool research project that was just done or published in 2023 called Toward a New Understanding. So it's done by UCSF. It's kind of the largest study of homelessness since the 90s. They did a ton of really cool mixed methods research, lots of interviews, focus groups, questionnaires, and some quantitative data to kind of get a better sense of like who is the homeless community in this day and age. And this is largely focused in California. But a very, very cool read. And a couple things that I think are important to highlight from here, things that I found most fascinating. They do a lot of digging into from a qual and quant perspective, like what precipitated homelessness for a lot of these individuals. And again, we'll dig into each of these points individually on the next few slides. But in terms of kind of triggers for homelessness, they found that a lot of these folks were coming from incarceration. They were coming from hospitalization or health crises, or kind of a period of unstable housing. And then migration is another misconception that I think a lot of people have regarding homelessness. You always hear, people talking about, homeless rates being so much higher in California because the weather's nicer. There's not as bad winters there or what have you. And they actually found that the majority of folks out there were from that area, oftentimes from the same county. So there's kind of pushes back against that idea. Chronicity of homelessness, I think, is something that's interesting and we don't always think about just in terms of how long folks spend on the street. But we'll dig into that a little bit. And most folks are not chronically homeless, but a sizable number of them are. And then with regard to kind of our world and in healthcare and thinking about healthcare access, health insurance is something that has come up a lot over the last few years here in Boise as we've been trying to find a way to expand healthcare outside of clinics. And there were similar concerns kind of brought up in this study, but interestingly, the vast majority of folks have health insurance, Medicaid, Medicare, good insurance that will cover a lot of things, yet still have a lot of difficulty accessing care. So we'll dig into that a little bit more as well. In terms of precipitating events, again, kind of the big categories that came out in this study were incarceration. About 1 in 5 of these folks were coming from an institutional setting, either jail or prison. And the vast majority of those folks did not have access to kind of preparatory resources or discussions about where they were going afterwards. And we've seen a lot of that here in Idaho. I know our hospital team deals with that a lot. Folks kind of just being dropped off on the streets or dropped off at the hospital. So that kind of holds true in this larger study as well. And then health events is another big trigger, especially among folks who had stable housing, folks who have a lease or own a house. Kind of their precipitating event for many of them was a health crisis, either of the individual who is the leaseholder or of a family member. And I think that's just an important thing for us to be aware of. I am often not asking people about their housing when I'm giving them a really big diagnosis or when I'm talking to people in the hospital, and I should be, and we all should be, because that can precipitate a lot of other downstream effects that we're not always thinking of. And then periods of unstable housing, about 50% of the folks in this large California study had kind of a prolonged period of unstable housing, meaning, couch crashing, staying with a friend, oftentimes not paying rent or not being on a lease prior to to completely losing their housing. And then within this population, the majority of these folks didn't seek help kind of in this unstable housing period. And so I think that's another population, another pathway to just be cognizant of when we're talking to our patients in the clinic or in the hospital about where they're staying and who they're staying with, and just being aware that this is a high risk period where they can easily transition from unstable housing into unhoused status. And oftentimes they're not at a point where they're kind of looking at resources in this stage. And so it's an important time to kind of catch that and potentially offer and connect to resources, really. In terms of migration, the California data found that about 90% of people in this population, they interviewed thousands of people, they lost their housing while in California. So these are not people coming into California from out of the state. And about 75% of them lost their housing in the same county. So the vast majority of these folks are from that area. They're from that county. They lose their housing and they stay there. And I think oftentimes you hear this a lot in the media, and I've heard this in conversation, even here in Boise, talking to folks about homelessness. There's a big misconception and kind of just negative view of any individual you see on the streets being somebody who's like coming to a location for the resources there, or coming there for the weather. And the reality is the vast majority of these people are your neighbors. And I think that's important to remember. With regard to timing of homelessness, chronicity, about 1/3 of folks in this large data set were chronically homeless. That definition is a HUD definition, means that they've been homeless for at least 12 months, or they've had at least 4 separate occasions that kind of add up to 12 months. And I think that's also just interesting, thinking about, the kind of the inflow and outflow of homelessness, the pathways in and out, and how many people kind of get stuck in that setting and don't find housing is only 1/3. And some estimates are about 20% of people or so kind of. That was a study that, I don't know, looked at the last few years. I think about 20% of them did not kind of find their way out of homelessness over that 1 year period. So a lot of people, I think the takeaway there for me is that a lot of folks will find their way out of homelessness one way or another throughout that year, which to me, I think is just something that gives me a little bit of hope thinking about this population. Okay, in terms of health insurance, the vast majority of folks in this population had insurance, like I mentioned earlier, primarily Medicaid, and then a mix of Medicare. That said, there's still a lot of lack of access to healthcare for many reasons, whether that's, many clinics don't take Medicaid or Medicare, or cap the number of patients they see, transportation issues, and then just kind of the all the other kind of social and stress barriers that prohibit somebody from kind of seeking a PCP. This population in general sees ED providers more than in general, and lots of them reported inability to access care. And this is relatively similar to what we've seen here in Boise, talking to folks that we've interacted with on the street or at the shelter spaces. Vast majority of folks here have insurance as well. Okay, gonna check how I'm doing on time here. Health impacts is kind of what we're going to talk about next. As many of you already know, this population has higher rates of pretty much everything: mortality, infection, mental health, chronic health conditions. We'll get into some of the numbers of those things in just a little bit. But mortality ratios are a lot higher, not unexpected. Kind of leading cause of mortality in these populations, and this is from a Lancet big review article from 2018. Largest contributing factors to kind of the differing mortality ratios were injuries, poisoning, other kind of external accidental causes. And then just lots of morbidity among this population that kind of impacts everything day to day for them: worse lung function, sleep quality, grip strength, psychological distress, and then high rates of pretty much everything, um, particularly infections and other conditions. And then in terms of care seeking patterns, again, majority of this population has insurance, but they tend to use healthcare resources very differently. A lot higher usage of acute care settings, whether that's, urgent care clinics or ER settings. And then this Lance article found that about less than 10% of kind of the population of unhoused folks who were using the ER, less than 10% of them were using the ER or accounted for more than 50% of the use. And so that just goes to say, even amongst the population of folks who are experiencing homelessness, there are a very wide range of how people use healthcare and how frequently people use the ER. And so this, again, is hard to generalize and should not be generalized to say that every individual using homelessness is constantly in the ER. That's not the case. And this kind of variance, even within that population, goes to show that. Readmission rates is something they also looked at in this study. And they found that in general, readmission rates were a lot higher for folks who were unhoused, 27% versus 17%. I believe that was over the next 30 days. And this was a multi-site study that looked at different hospitals, and they kind of clarified or classified these hospitals as homeless serving hospitals or hospitals that were more frequently had patients who were experiencing homelessness and had better kind of social services and kind of bridging programs. And in those specific hospitals, the readmission rates for individuals experiencing homelessness were actually lower than the general population. So that also just goes to show that a lot of this can be fixed with, or improved, I should say, with careful thought and planning and resources. And then hospital stays, they also found were a little bit longer on average. And I think maybe I was going to say something after that because there was a comma, but I never did. Okay, self-reported chronic health conditions by age. This is coming from that Towards a New Understanding study that we just went through. Again, just to kind of show, and again, you can come back to this later. We don't need to go through this line by line, but just kind of the breakdown of different kind of buckets of conditions that folks are dealing with. Lots of respiratory issues, and I know we see that here in Boise as well. Lots of cardiovascular issues, and then higher rates of infections like HIV and lots of liver disease. So again, kind of all across the board, lots of health issues. And then from a mental health standpoint, kind of again, drawing from the same data set here, very, very high rates of mental health issues. And then last thing to say about kind of health within this population, this is drawing from Ada County data, again, the 2025 PIT data. I just found it really fascinating, the difference in kind of mental health conditions and substance use disorders, again, self-reported, between sheltered and unsheltered populations. And so on the right, you see, 46% of unsheltered folks having mental health conditions as opposed to, 13% and 7% of folks within an emergency shelter or in some kind of transitional housing, and similar pattern for substance use disorder. And then, hard to say with HIV because it's rare in this area, but again, 2% within the unsheltered group and 0% in the other group. So all these health disparities that we're talking about, again, lots of variation even within the population of folks who are unhoused, and particularly worse in the unsheltered portion of that community. Which brings us to street medicine and kind of what to do about these things. Street medicine, many of you have probably heard of this. For those of you that haven't, this is kind of a multidisciplinary approach to combine health and lots of social and wraparound services. It's designed for individuals that are, quote, sleeping rough, meaning folks that are unsheltered and are out on the streets. Main goal of these programs is often to establish trust and kind of reconnect these folks to the health the health system, stabilize, lots of triaging, doing initial kind of care in the field, and then building connections and ideally getting folks plugged into care, with the idea being that street medicine is never going to be enough. You can't kind of recreate all the resources that we have in our brick and mortar structures, but it is a start, and it's a really important bridge. So within that realm, we've been doing a lot of things in Boise over the last few years. We're just going to talk a little bit about that now. I know some of you are already aware of some of these things. A lot of this is a work in progress as well. Medical outreach stuff we've been doing over the last few years. We've been kind of ramping this up in a very big way here at the Full Circle Health residency program in Boise. Starting in fall of 2024, the city had reached out to us and asked for help with wound care. And we started doing some monthly clinics at the shelter. And that was kind of our kind of initial step up into doing more clinical things outside of our clinic space. And then that kind of led to a year-long needs assessment that was done with lots of resident faculty support, and involved a lot of conversations with individuals at the shelter and on the street, as well as a lot of conversations with community partners, the folks at Catch, the folks at the city and our path and Trivium, and just trying to get a sense of, specifically in this community, what are the health needs that are not being addressed. And then we've kind of wrapped up that needs assessment over the last several months and are starting to put a few of those things into action. And what that's looking like for us right now is a couple touch points each month. One of those still being the monthly wound clinic at Interfaith, and then another, at least one other touch point in the month that is out on the street with our van. Oftentimes that's in partnership with CDH and Trivium, who are doing other kinds of health screenings and harm reduction, education, and provision of care within that realm. And then we've built a lot of time into our didactics for street medicine, which has been really great educationally, and then kind of continue to build up community partnerships and find ways that we can collaborate with other groups. And more recently, we're working on an EMT program to try to kind of get some more funding for just staff that can be out in the field from a medical standpoint and provide kind of more regular touch points and kind of bridge people as our partners, like, Catch, etc., are out there kind of encountering health needs. We'd like to have some more kind of formal ways and structured ways to connect those people to care. So that's kind of the medical outreach summary. From a data analysis standpoint, we've admittedly done a pretty bad job collecting data of touch points over the last year, but that's something we're working on. We have, from a clinic standpoint, also been working on some social determinants of health analysis. And this is, probably deserves a talk of its own at some point. And I just want to call out, really all I'm trying to do in this little chunk of the slide is call out how hard it is to collect data on this. We kind of took a chunk of patients who had diabetes, and we're just trying to see how much, their social determinants impact A1C outcomes and things like that, based on housing security and food insecurity, etc. And after, systematically trying to screen all these patients for health disparities, our data set's just missing a ton of data on social determinants. And so it's harder than it sounds like it should be to get good data on this. But I think I'm just throwing this in here as a plug to anybody who's either here or at other clinical settings throughout Southwest Idaho to think carefully about how you're collecting data and to do it if you're not, because it's really important to be able to kind of analyze your own population that you're serving, especially now with changes in national funding for these sorts of vulnerable populations. I think it's important to be able to back up what you're doing and why you're doing it, and that's hard without data. And then the last thing I just want to call out from a Boise standpoint, a county standpoint, is just the changing landscape here. Over the last year, we've been dealing a lot with anti-camping laws and um, which has really changed kind of the structure of where people gather in Boise. And from a street medicine standpoint, that's made it challenging to know where to find folks in the street and where to go to try to reach the most people with limited time. And so that's an unfortunate change here in Boise and something that we're still trying to navigate. And then shelter changes. Interfaith just moved their new shelter to a new location, and it's 24 hours, and it's incredible, and a really, really great service for a lot of folks. And there's no longer an emergency shelter downtown, so that'll be interesting to navigate over the next year as we kind of see ripple effects of that. Okay, take home points. These are just kind of the statements that were scattered throughout the PowerPoint, just things, again, that I thought were interesting from a data review standpoint, and kind of challenging misconceptions you might have about this population. And then really I'll just focus here as our time is running out on things that you might do. First, I just want to say street medicine and serving this population is very multidisciplinary. If you look at a lot of these programs around the country that are serving this population well, it is oftentimes not the physicians that are doing the heavy lifting. It is it's the nurses, the MAs, the social workers, the caseworkers, the behavioral health folks. And so this is an extremely multidisciplinary field. And if you have an interest in it, then there is a role for you for sure. If you are interested in this and are not involved, I think places to start is really just to kind of get to know your environment, whether that's Boise, Ada County, wherever you might be, and learn a little bit more about kind of the resources that are there for your patients and kind of identifying partnerships that you can form with different groups who are working in this area. And then getting to know your patients, asking questions so that you can intervene early. Again, thinking about those pathways to homelessness being, a huge one being health crises, either of the patient themselves or a family member. Those are important times to ask these questions. And then also, again, those kind of periods of unstable housing being an important place to try to intervene early. Again, just another plug to collect data from your clinical space on social determinants of health and housing status and how that might be impacting care outcomes. And then for anybody who's around the Boise area, who's interested in doing things outside of your clinic space, feel free to reach out to us here or start doing this. If you're in a different environment, just go out and start doing it. You do learn a lot along the way. We certainly have here in Boise over the last few years. But there's lots of resources out there and lots of community partnerships to be had. And plug for just the Street Med Institute is a great place to start if you're interested in getting started but not sure how. They have lots of resources in terms of how to do a needs assessment in your community or what questions you need to be asking, what kind of needs populations have in different areas, so you don't need to reinvent the wheel. There's lots of good resources there. And here are references for things that I used in this slide set, some PIT data from Idaho, national PIT data, homelessness is a housing problem, toward a new understanding, and then a couple different review articles. And that's all I got. Questions, thoughts from anyone?
Hey Tyler, I think such a great review. Thank you so much for doing all that and sharing all that. As we think about sort of our broader role in our community, I wonder if you came across or have any thoughts about public policy that is most helpful in these types of situations, especially in a place like Boise that just is so tight on housing. Are there things that we can advocate for as physicians in that space?
Yeah, great question. You're much more versed in the public policy arena than I am. I'm just dealing with the downstream effects of it most of the time. But totally, there's things to advocate for. I mean, I think the anti-camping ban is pretty horrific, and we're already seeing a lot of the health effects as people like, it used to be the case that by and large, folks with big health issues kind of stayed around the Cooper Court area downtown, and that's like not the case anymore. The cops are sweeping in that area and scattering people, so like we don't even know where to find people half the time. And then as as Boise grows and as the Treasure Valley grows in general, and housing is being developed, I think being really thoughtful about low income housing and transitional housing is really important. And that's like a whole nother um, realm of literature about like housing interventions that can work or help with this population. But again, coming back to that homelessness as a housing problem book, like that's where the money's at, I think, in terms of preventing things from getting worse and helping things get better, is really kind of addressing the housing availability. And then so any policy related to that, I think is really important. And again, that's hard when we're in a national space where like housing first initiatives are kind of being shut down. So that's from the top down becoming more and more of a challenge.
Yeah, awesome. Thank you.
Mm.
Are there any other questions for Dr. Shelby? There's one in the chat. Have you come across any health economic studies or projections that look at or compare the costs of places where safety net primary care is more available over emergency medicine?
I have not. That doesn't mean they're not there. They are out there. I just didn't have the time to kind of take an economics angle on this, but certainly there's lots of economic data on that.
Okay, do we have any more questions or thoughts?
Tyler, this is Justin. I'm just curious on a personal level, how have you been changed and what has this changed for your trajectory as a physician in doing all this care? Like hearing and touring the new homeless shelters that's in town, they couldn't say enough about like the work that's being done and the input that's coming in from there, specifically from
Mm.
you guys that's being in there. But so I know it's changing them and it's like letting us do things on a hospital side that we haven't been able to do before. But what has it done to you that's like filling your tank and keeping you going with it?
Yeah, good question. I don't know. I think something I reflect on a lot that's probably been a big like frame shift for me is I think when I like thinking back when I first started med school, um, and started working with this population in different ways in different places. Like I used to be, I think, as many people are, like very nihilistic and sort of like this problem's just too big to solve. It's just a mess. Um, and I think that's true in a lot of ways. And I think I no longer like approach this problem thinking that I have to fix it, um, but just like showing up and doing something or talking to somebody actually has like huge effects, and is a good way to just get familiar with the problem in a more intricate way. And I think like it's a scary problem and it's very big. And I think if you look at it through the lens of like, how do I fix this? Then you can get like paralyzed and like not, and then want to disengage because it seems very daunting. And so I think kind of shifting that to away from like, how do I fix this to just like, how do I make something a little bit better? Um, has been a big change for me. And that's made like me more engaged in it, for sure, and more comfortable in that space instead of like just feeling defeated all the time.
Thanks for that. And then I would say my second follow-up question, I mean, you kind of commented like just go do it, right? And I think that's a like a 5 mile jump to just go do it. Like what is a first step that any of us could take that would
Mm-hmm.
be like this is something you can do. This is how you go and volunteer one night a month to a homeless shelter. This is how you
Mm-hmm.
donate resources. What would be a step instead of that giant jump to
Yeah.
for someone to
Yeah.
access it?
Yeah, I think in a big way, what I meant by that is like find people who are already doing it in some way, and then go join them, or talk to your local community folks, whether you're in Boise or elsewhere, about what they need, and that might be help, serving food at the shelter. That might be something that's totally not medical, or in our case, it was a request for wound care, and we kind of just did that without knowing much and learned a lot along the way. Um, but there are people doing some variation of this in almost every location, and talking with them and joining them is a good place to start. And then the Street Med Institute again is like a really really big international community of folks that are doing this all around the globe. And there's just a ton of resources and tons of places to ask questions or get involved in resources and tools for like your own education and your training. Because yeah, there's a lot of nuance in terms of going out on the street and interacting with this population. There's also a lot of harm you can do if you go into this with the wrong the wrong energy and the wrong headspace. And so yeah, that's a great question. You do have to be thoughtful about how you're doing this for sure.
But sounds like there's a lot of first places to be able to go in.
Mm-hmm. Yeah.
Just okay. Thank you. And thanks for putting this talk together.
Yeah, absolutely. Ready. Thanks, everybody.